Hello friends, good afternoon. So today we are having a discussion about venous thromboembolism, which we commonly encountered in our clinical setting. So basically it results when a thrombus forms inside a major vein of the body, usually in the lower extremities. Disruption in the normal venous physiology such as any vascular injury, stasis or hypercoagulability leads to venous thrombosis. So whenever the thrombus forms, it can remain stationary or embolized to the lung, and as such the VTE comprises of pulmonary embolism and deep venous thrombosis. So the risk of mortality varies widely, but it can be as high as 10 to 30% within 1 month for the highest risk of patients. So traditionally it is classified as provoked or unprovoked. Patients with unprovoked or idiopathic VTE have a higher risk of recurrence. On contrary, patients with provoked have a very low risk of recurrence. Yet most of the patients, a combination of risk factors contributes to the VTE. So of note, the most recent VTE guidelines from the ESC have transitioned from provoked and unprovoked to the use of the terms major, transient or reversible and persistent risk factors. Similarly, transient and persistent risk factors are used by the American Society also for the management of VTE. So these are the surgical and non-surgical transient risk factors, and other are the non-transient risk factors. Transient surgical may be because of surgery or trauma. Non-surgical transient risk factor may be because of any leg injury, acute medical illness, any prolonged air travel, or pregnancy or estrogen therapy. While non-transient risk factors are particularly advancing age, obesity, cancer, frailty, or any chronic medical illness limiting the mobility, previous history of venous thromboembolism, any genetic cause, or certain other chronic illnesses like nephrotic syndrome, vasculitis, or IBD. So overview of anticoagulation, it is the mainstay of treatment for vast majority of patients. So exceptions of anticoagulation, like some patients have sufficiently low risk of progression or recurrence so that anticoagulation therapy may not be recommended. Include selected patients like DVT confined to the distal veins of the leg or patient with uncomplicated subsegmental PE. As per the recent guidelines, such patients require serial ultrasound or clinical surveillance rather than anticoagulation therapy. The serial ultrasound is typically performed 1 to 2 weeks following the diagnosis. And anticoagulation is typically initiated if any extension of the thrombosis is identified. So what are the risk factors for the progression of the distal DVT? If we have elevated D dimer, if there is an extensive thrombosis like more than 5 cm in length, multiple veins are involved, and if it is close to proximal veins, or if there are no reversible provoking risk factors, if there is an active cancer, if there is a previous history of VTE, or if the patient is indo. So anticoagulation therapy is conceptualized in 3 phases. There is the initial management phase, then the primary treatment phase, and other is the secondary preventive phase. So it should be noted that these 3 phases have previously been referred as acute, long-term and extended phase. So more recently guidelines have used the terms initial management, primary treatment and secondary prevention. So talking about the initial management, which is the first 3 weeks. So any active thrombus must be halted through rapid and intensive anticoagulation in the initial management phase. So it is achieved either with intravenous unfractionated heparin or subcutaneous LMWH. More recently, the direct oral anticoagulant have also been shown efficacious in this phase. So either we can choose a parenteral therapy or a higher dose of oral anticoagulation therapy. So patients are treated in acute care setting are likely to be treated with a parenteral molecule, which is very effective and rapidly cleared from the circulation. LMWH are typically administered subcutaneously, carrying a lower risk of heat, have a longer duration of action, suitable for once or twice daily administration, do not require routine monitoring, and also be used for prolonged phases. 2 other oral drugs like apixaban and rivaroxaban also can be used in the initial management phase. So it is advantageous for patients with strong desire to avoid parenteral therapy or who are suitable candidates for treatment at home. Other molecules like dabigatran and digoxin also require a 5 to 10 day lead-in with either heparin or LMWH before initiating the oral therapy. Next comes the primary treatment phase, which is the first 3 to 6 months. So all the patients with acute VT are recommended to receive at least 3 to 6 months of anticoagulation in the primary treatment phase. And it represents the period of highest risk of recurrence when the body's natural thrombolytic processes are recanalizing the vein and converting to chronic fibrin. Options include warfarin and direct oral anticoagulant, including the direct thrombin inhibitor and factor Xa inhibitors, apixaban, rivaroxaban and edoxaban. So typically we can say that initial management phase we can either give with intravenous or sub-Q molecules, or either we can start with rivaroxaban 15 mg BD for 21 days or apixaban 10 mg BD for 7 days, and then we can switch over to the lower dosages as shown in the chart, which constitute the primary treatment, that is 3 to 6 months. And then for secondary prevention beyond 3 to 6 months, based on the individual clinical profile, we can decide for continuation of anticoagulation at a lower dosages. So for warfarin, it acts by inhibiting the vitamin K epoxide reductase, which is responsible for reduction of vitamin K. It inhibits the enzyme, results in a functional deficiency of vitamin K dependent clotting factors. It has a narrow therapeutic index. INR target is between 2 and 3. Initial prothrombotic phase is also there because of the initiation of natural anticoagulant protein CNS, as well as long-term half-life of vitamin K dependent clotting factors. So in that case, it should be done frequently, at least weekly, until a stable range is achieved. For the direct oral anticoagulant, dabigatran, rivaroxaban, apixaban and edoxaban are available, and they are to be used according to the dosages mentioned in the table. Similarly, at present, 4 molecules are FDA approved. Dabigatran and edoxaban requires 5 to 10 days of parenteral drug therapy running, does not overlap or bridge as with warfarin. So the most recent ACC guidelines recommend DOAC over warfarin. Special indication for warfarin include like if the patient is having severe renal dysfunction, if there is a triple positive APAS, or if there is a cost failure. DOAC clinical trials, these are just an overview of the different clinical trials of the direct oral anticoagulant. There is a RECOVER trial for dabigatran, Einstein DVT trial for rivaroxaban, and PE trial for rivaroxaban, and Amplify trial for apixaban, and Hycosave VT for edoxaban. So these are the different factors which help in selection of appropriate oral anticoagulant molecule, depending on the frequency of the dosing, the history of GERD or PPI use, desire for close monitoring, as well as dose timing with regard to food or other meals. DOAC appears to be a reasonable alternative to LMWH in the treatment of cancer-associated VTE. Higher bleeding rates are seen among the DOAC treated patient in this because of GI or urinary origin. In the secondary preventive phase, the duration of is best determined by the review of individual patient's risk. Several risk scoring algorithms exist to help quantify the risk of recurrence of VT. These include the main continuum, Versus 2-score, Vienna risk model, and DASH prediction score. They consider various patient-specific factors and help in arriving at the stratification. So this is just a flowchart of management of DVT and PE, and according to the presence or absence of different risk factors, you can determine the mode and the duration of anticoagulation. So this is the RIT and VT associated bleeding risk score, READ score, and VT bleed risk score, which take into major criteria like recent history of nascent major bleeding, creatinine, anemia, cancer, pulmonary embolism, age, etc., and help in arriving at the stratification. For secondary prevention, low-dose DUAC Einstein choice trial was there, in which rivaroxaban 20 mg daily was compared with rivaroxaban 10 mg daily and aspirin 100 mg daily. So both doses of rivaroxaban were found to reduce the risk of recurrent VT similarly to a greater degree than aspirin. Similarly, for secondary prevention, amplified EXT apixaban 5 mg twice daily was compared with 2.5 twice daily, and they have similar rates of low rates of recurrent VT, and both were superior to placebo. Rates of major bleeding were numerically lower in the apixaban group than in the placebo group. Similarly, both apixaban and rivaroxaban are labeled in the US for their use in lower dosages after 6 months of therapy at the standard dosage. They are a good option for patients with weakly provoked VT, particularly like long car travel or air travel, or patient with unprovoked VT, and there is no high risk features, so they are a good option. Similarly, the Warfasa and Aspire trials show that in patients who are no longer anticoagulated, aspirin provides some protection against recurrent events. So aspirin may be considered for recurrent VT risk reduction in patients who have opted not to continue anticoagulation and do not carry high risk of bleeding. So this is just methodology for selecting various venous thromboembolism, anticoagulation, and duration. So we have to determine the phase of the treatment which we are targeting, and we have to identify the different risks for recurrence, as we have already discussed surgical and non-surgical transient as well as non-transient risk factors, and you have to also screen for the risk of bleeding. And then we can select different anticoagulation molecule. And similarly, if there is a very low or a very low recurrence risk, there is no need for secondary phase. If there is a moderate recurrence risk based on the bleeding profile, we can consider it. If there is a high risk of recurrence, then we have to include both the initial as well as primary as well as secondary phase of anticoagulation. So these are the important different guidelines how to monitor the patient who are on anticoagulation. For patients who are taking any anticoagulation, you have to risk assess for the sign and symptoms of worsening or recurrent thrombosis, sign and symptoms of bleeding, potential for heavy menstrual bleeding, pregnancy prevention, duration of therapy, and avoidance of certain over-the-counter medicines that increase the bleeding risk, avoidance of certain behaviors that increase the bleeding risk. And for patients who are on DUAC, it is important to explain the patient regarding the medication adherence, especially for warfarin patient. If we consider, there is very important of INR monitoring in these patients, awareness of certain sources of vitamin K in nutritional as well as supplements as well as vitamins. Certain lifestyle changes also affect the INR, like exercise, alcohol, tobacco, certain acute viral illness or interacting medicines. And we have to notify it appear they are different in color and shape with each medication refill. So direct oral anticoagulant have revolutionized the treatment of VT. At the same time, they have also introduced certain newer complexities in the management. So it includes the different dosage and regimen for different indications, different approaches to peri-procedural management, and the need to understand complex drug-to-drug interaction. Certain newer class of antithrombotic medications are also under development, which include novel direct thrombin inhibitors of factor 11 and 12, and selectin antagonist. So to summarize, we can say that VT is a very complex problem, represents a significant statistical public health burden, especially for an aging population. Although many patients have identifiable provoking factors, it is increasingly recognized that unidentified head factors contribute to an individual's risk of initial and recurrent VT. In the past decade, the DOAC medications have transformed both the acute as well as the secondary phases, and additional antithrombotic therapy are currently under development, and they offer hope for treatment with lower risk of bleeding complications. Thank you.